Hello, my name is Blake Fagan. I've been a family physician since 1998. I do inpatient work and outpatient work. I see pregnant women and deliver babies. About 30% of my practice is kids. And I'm the CDC Foundation North Carolina Clinical Consultant for the Opiate Crisis and Chief Education Officer at UNC Health Sciences at Mayhew. Today I'm talking about myths surrounding buprenorphine. These myths lead to barriers to effective treatment. This information is derived from Wakeman and Barnett, Primary Care and the Opiate Overdose Crisis, Buprenorphine Myths and Realities in the New England Journal of Medicine, July 5, 2018, and from Martin et al., The Next Stage of Buprenorphine Care for Opiate Use Disorder in the Annals of Internal Medicine, October 23, 2018. Myth number 1, buprenorphine treatment is dangerous. As a matter of fact, buprenorphine is safer than being on oxycodone, hydrocodone, or hydromorphone chronically. If a patient takes too much buprenorphine, their respiratory rate does not go to zero. Buprenorphine is simpler than titrating insulin or starting anticoagulation. The issue is that, unfortunately, providers receive little to no training in it. Myth number 2, prescribing buprenorphine is time-consuming and burdensome. In reality, prescribing buprenorphine can be rewarding and hopeful. To ease the load, please know that in-office inductions and intensive behavioral therapy are not required for effective treatment. Most patients know how much buprenorphine they need to stave off withdrawal and cravings, making home inductions easy and effective. Myth number 3, typical primary care doctors can't do this if they don't have on-site counseling. This is related to myth number 2, but as a matter of fact, primary care physicians, internal medicine docs, OBGYNs, and others can do MAT and then connect to behavioral health counseling that exists in their area. The evidence-based data suggests that medication is what helps the stabilization. Behavioral health counseling is beneficial, particularly early in the recovery, but it is not something that has to be done in the same office. So refer out. Teamwork is great. Myth number 4, buprenorphine is a short-term treatment. It should be prescribed in tapered doses to just detox patients off opiates over weeks or months. In reality, the vast majority of patients with opiate use disorder have experienced some brain changes. If they are tapered off the buprenorphine too quickly, the cravings will come back. Buprenorphine should be prescribed for as long as it benefits the patient. And in fact, quickly tapering or detoxing patients may increase the likelihood of overdose and overdose death by eliminating their tolerance. As the cravings come back, they go back to using the same amount of oxycodone or heroin, but they've lost their tolerance. And this can lead to overdose and overdose death. Myth number 5, medication-assisted treatment for opiate use disorder is just substituting one addiction for another. In reality, addiction and dependence are not synonymous. As a matter of fact, addiction in the DSM-5 is defined by continuing to use a medication over and over again despite the harm that it is doing to the person and those closest to them. If you're in your use disorder, then you lose your job, your significant other, maybe the custody of your children, you can overdose, and you may even continue to use despite getting infections. However, there is hope. Once you get on medication-assisted treatment like buprenorphine, it is taking care of 2 things, cravings and withdrawal. Buprenorphine allows stabilization so that you can succeed at life. Because you're not having the cravings, you're not getting into trouble with the law. You can do the cognitive behavioral therapy and regain control of your life. So it's not just substituting one addiction for another. The medication is stabilizing. If you believe that opiate use disorder is a chronic disease like diabetes or high blood pressure, then you treat those with medications. For instance, think of a patient who has diabetes and their diabetes is out of control. What do? You see them often, you dial up their insulin, then after 6 months their diabetes is under control. The next time you see them, you don't take all their insulin away. In this case, the patient is dependent on the insulin, but is not addicted to it. Opiate use disorder causes brain changes, and in some people, they need a medication for an extended period of time. Just because you need a medication long-term does not mean you're addicted. It means that you are dependent. Indeed, some people will be able to wean off the medication, but the majority of people are going to need it for a long period of time. Myth number 6. Patients are diverting and scamming for Suboxone so that they can get high. In fact, the vast majority of buprenorphine being used not as directed is to avoid withdrawal. On the street, patients are using it to stave off cravings and withdrawal. They are trying to keep from getting dope sick, because buprenorphine is a partial agonist and not a full agonist. How does it work? Buprenorphine has a ceiling effect. In other words, it does not allow the patient to get high. Suboxone is the combination drug, buprenorphine plus naloxone. The brand name of that is Narcan. It has a built-in deterrent. If you melt down the Suboxone and you inject it, then you will go into full-blown withdrawal because of the naloxone. Can you abuse it or not use it correctly? Yes, but it has a big deterrent effect. Myth number 7. Frequent return to using illicit drugs means treatment doesn't work. If you approach opiate use disorder like a chronic disease, then the treatment, MAT, is as effective as that of other chronic diseases. In reality, if you believe that it's a chronic relapsing disease, which it is according to the CDC, the NIH, and the WHO, you are expecting to have folks who do well on the medicine, and then at other times, they're not doing as well. If you go back to the diabetes analogy, sometimes our patients have a hemoglobin A1C of 7, and then 3 months later, they have an A1C of 10. Well, what happens? We don't kick them out of our care. We see them more often, and we continue to help them until their diabetes is under control again. Now, back to our patient who has opiate use disorder. If the patient has heroin in their urine drug screen, it's an opportunity to do 3 main things. Number 1, talk about what their triggers are that made them kind of backslide. Number 2, see them more often. And number 3, get them connected to behavioral health services. The bottom line, as exemplified by the harm reduction model, is we do not use urine drug screens to kick them out of our practice. Instead, we meet them where they are and support them throughout the whole recovery process.